We spent some time in Bern together, so he will give his first talk about post-operative supportive care improving quality of life, a surgical theme. Thank you.
So, dear Chairman, thank you very much, and I would like to thank the organizers for the wonderful congress. Great talks today, great discussions, and my talk is about post-operative supportive care. And as I read the first time the slide and the title, Improving Quality of Life, I actually knew what I have to say. But I really want to thank for the session before, for the surgical session, Professor Büchler and Professor Neoptolemus, I really agree with them. And what you said is, if we want to push the borders forward in surgery, we really have to think about toxicity in surgery. And if we can improve quality of life, and if we can improve even more to reduce the toxicity in surgery, we can push the borders even more further. So if you talk about supportive care, you really have to see that we are not dealing with patients who look like this. We are dealing with patients who more or less at the end look like this. You know, this is Steve Jobs. He had a pancreatic disease, and he suffered from weight loss and so on, and maybe if we could have improved the supportive care with him, maybe he would have lived longer. And if we talk about supportive care, we have to talk about the effects, and I would like to show you two papers which I found really impressive, and I had, when I first started with that, I had read this paper of Cow, who said environmental genetic activation of the brain adipocyte BDNF axis causes cancer remission and inhibition. And what did he do in this paper? He said that there is an enriched environment. And what he meant with the enriched environment, he had mice living in a cage, which was really one cage per mice. And the rats and the mice had two things that they can really deal with. They really have an enriched environment, not living in three in a cage. And what you see is that in this enriched environment, you can reduce the tumor growth up to 77%. Maybe the tumor occurrence after induction of the B16 cell lymphoma was delayed, and in 17% there was even no tumor growth. They concluded and they showed that this may or might be due to the BDNF leptin axis, and this shows that you have really things which a patient can deal with. You can have some success, even more than quality of life. This can be translated into humans, maybe. So you all know the paper of Temel at co-workers where they published the early palliative care for patients in lung cancer patients. They had a randomized controlled trial, and they had included 150 patients, which they offered standard oncologic therapy versus standard oncologic therapy plus early palliative care. And what did they do in this early palliative care situation? They really had a team of psychologists and pain therapy. This had to be at least 4 visits. And what they can show in this early palliative care setting, that the patients had a better life quality and a less depression score. And what they showed in this paper, 2010, was that they had a longer survival, compared 11.6 months to 8.9 months in the early palliative care group. However, they published now just recently a post hoc analysis and stepped a little bit back from this longer survival. In this paper, the word survival only showed once in this paper. I looked it after. And what they saw is that the patients who are younger than age of 65, or if they are older, they differ in the responsiveness to the early palliative care. You see, the younger patients in the early palliative care, they really benefited a lot from this intervention, as the standard care was really not so successful. But this was not true in the age of 65 and older group. There, the benefit of the early palliative care setting was quite less. And even if you show the gender distribution, if they looked at it, you see that the male patients are really profiting from this early palliative care setting, whereas the female group is not really so beneficial. However, it remains to be seen if early palliative care, if enriched environment, taking care for patients or mice is really beneficial of the patients. But what we are seeing and what I see from my practical work, and this is what you know in every scene and in every slides, which shown that sport and cancer, so physical activity, is absolutely recommended for these patients. And there are a lot of publications. These are German publications, but you see they are very early published that the patients can benefit from physical activity and sport. My paper and my thinking, and this was what Wendy Davidson published it, that if you can stabilize the weight in patients with pancreatic cancer, with unresected pancreas, you can improve survival and quality of life. And this paper I found really astonishing. And then there was absolutely the question, when we have a weight stabilization, how is it in surgery? How is it in surgery when we have patients who have been operated? And we had a look at the patients, and we followed them up to 12 months and longer. And what you see, they have a pre-operative weight. The patients who lost a lot of weight, this is the Cachexia group, and the patients who had quite a stable weight till the operation, they came down to almost the same weight. But then, up to 6 and to 12 months after the operation, these patients lost weight, respectable if they are cachectic or not. So it's not like most of the surgeons think after 3 weeks or 6 weeks the patient is well again. We have to deal after operation a little bit longer, up to 12 months, and up to 18 months you have really regained weight from these patients. So we really have to take care of this patient. And does this have an impact? If you ask a patient before the operation, did you lose weight or not? And I can tell you yes. And it's a simple question, and you have a stable weight patient, or you have a patient who gets resected and has weight loss. You see, this have an impact. This has an impact on the prognosis of these patients if they are operated later on. So when we talk about cachexia, about losing weight, about supportive therapy, we first have to look and have to think. And this is quite funny. We know the word cachexia since we all studied that cachexia is a word which everybody knows, but what is it? And this question is not so easy to answer, as you see, because there are several pathomechanisms of cachexia. There are a lot of things which are working on cachexia, and if we can really put it to 2 parts, we can say we have 2 components in cachexia. And in weight-losing patients, irrespective of operation or chemotherapy, we have the anorexia part and we have the wasting part. The wasting part is most probably mandatory from the tumor, so it's mediated by the tumor. By chemokines, there is IL-6 and other cytokines really working. You have a nettoproteolysis in the muscle, lipolysis, and then we have the anorexia part. And if you have the anorexia part, the surgeons are not really the ones who are not responsible for that, because we are operating, and Professor Bühler showed it very nice and very good, we are operating in anatomic part where you have a lot of nerves, where you have a lot of invasion in the tumor into vessels, and therefore we have to really see that these nerves do have a function. And if we talk about function, I show you a picture about the esophagus, and this part is then really something what you have to look for. This part contains the plexus ciliacus. It's at the truncus ciliacus, what we have seen if you are resecting the artery and so on. Here are the 2 brothers. And what you see is that the complex regulation of motility in the esophagus, the complex regulation of the motility in the gut is not so easy. It's not one nerve. It's much more nerves you need much more nerves to come to a really good regulation. And if you then resect in the pancreas, and you see it at the truncus celiacus, which is really a key regulator of gut motility, you see this is this kind of part here. And if you go down to the aorta, which you see here, you resect a lot of the plexus celiacus. So what the patient might get if you are too extensive is that he will have diarrhea for his lifelong, and you have to be sure that you can control this, and you have to be sure that you have the ability to really control this diarrhea, because otherwise the patient will not have a good life quality. This you have always to take in mind, and I'm sure Heidelberg has this in mind, to see if you are really resecting at the border, and this is what I mean in toxicity in patients after the operation. So, and if we talk about weight loss, we are not able to really define weight loss at the moment really correctly, because if you see these two patients, they have the BMI of 24 and they have the same BMI. But if you look at the patients more exactly, then you will see that this patient and this patients are completely different. This patient, he has a pancreatic adenocarcinoma. You see in red, this is a CT scan at the level of L3. You see in red that there is a lot of muscle. And this is visceral fat you have, and this looks quite normal. At the same patient with the same BMI, you see there's nothing red anymore. There is a lot of visceral fat still there, but what you see is green, and green is the fat which replaces the muscle. And I got this picture from Semi Antun, and he just really could show very nicely that these patients do very bad to chemotherapy, and they will do even very bad to surgery, because they have no muscle anymore. They will respond quite hard to toxicity, and they have really he showed it in the chemotherapy. They have these are the patients where you have to have those limitations, where you have increased toxicity and you have increased complications. Whereas this patient, irrespectively of the same BMI, does much more better. What we do and what we are really aiming for is to see how can we define cachexia now. And this is the point what was really funny. We have 2008, the first definition, and this definition was about weight loss at least 5%, and we have serum albumin, we have CRP markers included in this definition, and we already said when this definition came out, it's not a useful definition even for clinicians. Then 2011, the next definition from Fearon. Consensus statement, we defined Cachexia, he defined it in 5% over 6 months. This was also true if you have a BMI less of 20, and the first time here it came to be the appendicular skeletal mass into discussion. So muscle is important. He, and this is what I liked at this definition, he claimed for stages of cachexia, he claimed for stages of weight loss. And this is a kind of stage we have pre-cachexia, we have cachexia, and then we will have a refractory cachexia. This means when you wait too long, you can't get out this patient of his state of cachexia. And this is important. If you are treating these patients, you really have to start quite early. Then 2015, even 4 years later on, I think we have 2018, the next definition. The definition was a bit better. I think you have a weight loss of 10% of body weight, BMI below 18.5, and you have the free fat mass index below 15 and 17 for women and men. This is quite near to the definition of the BM or the free fat mass index in normal patients. So, but it's really a good definition to work with. And what can we do and what did we do? I can show you. We have conducted 2010 already a nutrition and exercise center for cancer patients. And this was for us quite logical, because what we did, we tried to standardize, evaluate nutrition in sport. Of course, it is an observational study, but we had a lot of parameters included, like lab values, nutrition, sport and performance, and quality of life. And if you look at these patients, after this, these are all the patients. We have now more than 600 included with 1,100 visits. But these are the patients who really conducted the complete program. And what you see is that we are able to stabilize the weight for 6 months. I think this is a good result for observational study and for really already stabilize the weight. If you have in mind my slide I showed before, that patients after operation lose a lot of weight, we are happy to stabilize this weight. And we really could improve the performance of these patients about to 20%. And this improvement of performance is also significant if you look into the work a patient can do per kilogram body weight. But in these patients, when you look at these patients again who lost a lot of weight, they are dramatically dropping in their capability of performance. So it's patients who lose weight have 25% loss of performance. And this is also true in the relative performance. What does this mean? They realize this. If you look there, you see that the global health score is not so dramatically different. This is the quality of life score, the EORTC. But the physical functioning, they realize I cannot really act like before, and I cannot really have my role functioning again. The cognitive functioning did not lost a lot of brain. It stayed the same. And so what are additionally therapeutic options for these patients in terms of supportive care? You should first, and this is very important, this comes now up into the clinics in Germany, it's almost mandatory, you should really set a score for these patients. I would recommend the nutritional risk score for patients which are in hospital. This is the publication from Kondrup et al. For this. This is validated for oncologic patients, and maybe the must score for patients who are in an ambulance setting. But the NRS-Score is working. I can show it to you at this slide when I go back again. So you have, no, I'm sorry, I have it not on this slide, but this is not, I can tell you the NRS-Score in patients with Kachexia is really 3. And 3 is that where you have to intervene. And the patients which did not have a Kachexia is 1. So 1 is okay. And I did not expect this because I said 4 questions in a patient, this would not have an impact. But if you ask these 4 questions and if you score like the NRS-Score, you really get a definite discrimination in patients who need help in nutrition and exercise and patients who do not need help in nutrition and exercise. Further on, and this is the slide you really should remember, if everybody forgets all the slides but not this, I'm really asking for this, really try to get an early intervention. If you are late, if the patient lost enough weight, you are not able to come back again. He is refractory in his Kachexia. So you have to start early in the treatment and early intervention of nutritional intervention. The study has been shown most beneficial for the surgery, and even for treatment in palliative settings, you have to start it early, otherwise you will lose. Treatment is first the supplemental oral nutrition, then you can take with dietary supplements, you can take total parental nutrition, and we have a part of pharmacological treatment, but this is not developed a lot, so we really should start with the supplemental nutrition and then really, again, come with the other treatment options. If you then ask what is more important, is it the oral nutritional support, the ONS, or is it really the sport? And if you look at our patients, you see that the performance of these patients, if they done no sports or if they done sport with oral nutritional support or without, you see it's almost the same at the start. And then we should look at the performance gain. And what you see is the patients who done no sports at the beginning and are taking oral nutritional supplement, so they really had the most performance gain in these groups. This means if you are doing no sports and only nutritional support, it will not have an impact. You have to do sports, and after 6 months, if you are doing sports, you really get a performance. And this is the second group who really had a performance gain, were the group who had sports and then had oral nutritional supplement. They are starting together. So it's a team. So it's working together. If you are doing no sports and no oral nutritional supplement, even after 6 months, you have no performance gain because you have not the nutritional support and not the physical activity support. You really need to do both. And if you're doing both, you really get the performance gain. We also conducted, and this I would like to invite you, if you are sometimes in Munich, we do this once a month. You can just come up and ask me. We are doing now a nutrition course for patients who are operated and who had a chemotherapy to really gain or keep their weight. This is in cooperation with quite a famous cook. He is called Schubeck. We get a very positive feedback in this nutritional course, and we really get new insights because every time the patients are asking different questions, and even the evaluation of the course tells us that the patients are gaining weight really very effective, even if we only have a nutritional intervention for three hours. Let me conclude that cachexia is a frequent symptom. It's a symptom complex, but we have to keep it in mind. And even in pancreatic cancer patients who are eligible to operate, 40% of these patients already have cachexia. So we have a lot of patients which we really can improve and push the border for surgery and reduce toxicity. We have a really significantly prognosis with weight loss. It's a bad prognosis with weight loss, so we have to improve this, and we have to improve this very early. And what we know, if we have a nutritional intervention, please first screen the patient. This is really important to see if the patient needs intervention or not. And what we can say that the pharmacological options are still into development. There is some promising results, but too less to report and too less time to report and too less patients. And I really thank you for your attention.